Thank you for having me. I am super excited to be here to talk with you all today. Um, so I am a cisgender female, straight and white, and I share those things partly as a reminder to acknowledge those factors. I am speaking from a largely majority experience. I have not faced discrimination and stigma in these particular areas of my life, and so it's a reminder to me that I have to stay humble in this work and be open to learning and getting feedback. And that is super important when working with people who are sexual and gender minorities. This note is from my very first patient that I worked with in hormonal transition to transition from male to female. Kind of a small town moment. I was getting my tires changed, and they work at that tire change place, or they did at the time. And when I got in my car, this little note was on my dashboard. Thank you for everything you've done to improve my life and the way I feel. I will always be grateful. You gave me a great life. And totally brought tears to my eyes, and was reaffirming as to why I do this work. A lot of what I've talked about in the past is in regard to transgender care. And today we're going to be talking about LGBTQ, the entire spectrum. But some of my focus will be on transgender because that is a lot of what I do in my practice. I, like many of you, probably didn't get much training, if any at all. I had no training in transgender care in residency or medical school. I had maybe a little bit on LGBT care, but not really much at all. So I came into my family medicine practice, and about 10 years ago, I had this patient who gave me this note come to me and say, "Hey, will you help me with hormones?" And I said, what kind? And he said, the female kind. And I had no training. I had no experience to know how to respond to that. And it really kind of took me off guard. But fortunately, I'd had enough life experiences of exposure to people who identified as LGBTQ to be coming from a place of acceptance and welcoming, and was able to say, yeah, I can do that with you if you're willing to be the person that I learn, from. And gratefully for me, they were willing to do that. And that has started my practice. And I found that there was a huge need in Southeast Ohio. I have people that come from as far away as Charleston, West Virginia, which is about an hour and a half away, because they can't find anybody locally. There may be people there, but they aren't announcing themselves to be affirming or knowledgeable. So I have people that come from very far away. There is a huge need, and not many people are saying, hey, this is something I'm willing to do for you. Today, there's a lot of different backgrounds watching this presentation today, but I just wanted to make sure we talk briefly. We could spend an entire time talking about language, but I want to make sure we do talk a little bit about the continuum. We tend to put people in boxes: male, female, straight, gay. People do not live that way. People are not like that. People are, and even this diagram shows it in 2 dimensions. It's much more 3-dimensional. It's much more dynamic and changing all the time. And so part of the ways we get ourselves into trouble is when we make assumptions that people are in one of the boxes that we typically think about people being in. So I just want to remind us that this is a continuum. People are moving along it and changing throughout their life course, and it is dynamic. And this is about us. This is us. We all have sexual orientation. We all have gender identity. I know some of you listening today have really had to think about, consider, ponder this, struggle with these issues. And many of us have not had to think about that. But regardless of whether we have had to think about it, we bring it into the room with us. It is a part of who we are when we come into the exam room, and it informs our perspectives and our biases. So we absolutely must examine it. So from the pre-readings, you saw that there are lots of different LGBTQ health disparities, from depression, anxiety, substance abuse. Those things are not inherent to the LGBTQ population. They come from someplace, and they largely come from the ways the bias is enacted at multiple levels. The individual, how we internalize it, how we take on qualities that others are saying about us, are interpersonal, and that's what's really important for us as physicians or future physicians, how we interact with patients. But also we have a potential role in the social and structural aspects as well. And so we're going to talk a little bit about that. Moving it to kind of the rural setting, an estimated 2.9 to 3.8 million people live in rural America. Some people say, why would you live in a rural area? Don't you face more discrimination? Well, people live there because being LGBTQ is only one part of their identity. They also want to be close to family, close to that rural way of life, the strength of communities, the connection to the land. So there are a lot of people. It's estimated, I think, 3 to 5% of the U.S. population identifies as LGBTQ, and that's on par for what we see in the rural areas as well. This diagram and the next one came from a resource I found called Where We Call Home, LGBT People in Rural America, 2019. So I would definitely guide you there if you want to know more information about that, because it was a great resource on all things LGBTQ in rural areas. And there's lots of strengths that come from LGBT people living in rural areas, but the rural life, this slide shows how rural life amplifies the impact of acceptance and rejection. So there's issues of increased visibility. There aren't as many other people who maybe look like you or have a lifestyle like you. The ripple effect that, if you're out in one setting, you maybe don't want to be out in your church or your work setting, and yet that may happen whether you want it to or not. There's fewer alternatives where you get your health care, may be very limited, and if you are denied care at one place, you may have to drive a long way to seek care. And then there's less support structures in place. And all of these things have huge impacts on your education, your employment, your housing, and of course, your healthcare. And I also want to make sure I say here too that all of these things are further amplified for people of color, what I also like to call people of the global majority. And so we have to take that into consideration too, that people of color, when they are in small communities where they are in the minority, and also a gender or sexual minority, then they have further amplifications of all these things. And these, as you know, these ways of discrimination and stigma really play a role in our health. They lead to adverse mental and physical health outcomes. The internalized stigma leads to the self-harm and unhealthy, risky behaviors as people are trying to cope and deal with how they feel inside and how they are treated by the external world. And then, of course, the fear of discrimination by healthcare providers has a big impact. So those are some of the barriers to healthcare, but there are a lot more. Providers being one of the large ones that I want to emphasize today. Do you have the knowledge and skills to provide adequate care and appropriate and affirming care to LGBTQ patients? Have you been taught it? Have you learned it? Have you gone after it? There's some systemic problems there that we don't emphasize this enough in our education. And then, of course, what are the attitudes that you come into it with? I'm assuming that most people watching this are coming with not an explicit bias towards LGBTQ population, but obviously there are doctors who will say, I will not provide you care. But we all have implicit biases, which we'll talk about more. And there's huge financial barriers, transportation, insurance, employment, housing, all those things make it harder for people to get to appointments. I have lots and lots of people that I take care of in my transgender population that miss appointments all the time. And in our policy, you miss 2 appointments on the 3rd no-show, you could risk being discharged. And so I've had to think a lot about how I handle things like that, because I know how many more barriers they're facing. Geographic, legal immigration status, that can be an important issue some places. And then hugely, the negative experiences people have had in the past. Every time somebody walks through my door, I'm aware that they have had probably some negative experiences along the way with how they were treated or how assumptions were made about them. So stigma and biases are everywhere. They aren't limited to any certain geographic locations, but in the rural settings, there may be fewer visible contradictions. There's fewer signs that who you are is welcome. For example, the Columbus Pride Parade that happens every summer goes on for 2 or 3 hours. Thousands and thousands of people show up. You would know that there are lots of people in your community that are supportive of who you are. But for example, in this town in Palermo, Maine, population 1,500, when this church put this sign up, Jesus made Adam and Eve, not Adam and Steve, the gay couple who lived in this town felt very attacked and very isolated. And they had lived there for a long time, and now all of a sudden there was this sign in their community that made them feel not welcome. And churches can be a big role in that, in providing a different kind of message. Here's a church that decided to make a very explicit message to their community, also a small town in Kentucky, saying, hey, we support marriage for all couples. You are welcome here. So, the signs can be present in a more positive way, but often in the small communities, you don't have a lot of signs that who you are is welcome. I called this slide clean feet because I used to work with somebody who said, oh, my feet must be the cleanest feet in town. I'm always sticking my foot in my mouth. And I always like that because we all make mistakes. We all make assumptions and missteps. I do it on a regular basis for lots of different issues, lots of different ways. And largely it's coming from the implicit bias. You know, we live in a culture that is majority heterosexual, majority cisgender. It's the water we swim in. It's what we see in the media. It's what we see modeled around us more often than the other options. And so we all have this implicit bias, and it does not make us bad people. It doesn't. I think we have to be really clear about that. But it does give us a responsibility to respond when we see it happening, to reflect on our bias, to be curious about it. Oh, wow, look what I just said to that person. I just assumed that, you know, 2 months ago they were dating a man, and now they're dating a woman, and I assumed they were still with a man. Lots of different ways that I put my foot in my mouth because I'm not being open enough in my thinking about how people might be living. So thinking about actions that you can take, this is probably the slide that is most important to me of all these slides, and it is my approach to all my patient care. And it is to do your best to let their whole person show up. Let the entire complexity of who they are to come into your room, and know that whatever they share, whatever thing that they are, you know, embarrassed about, they have shame about, that they keep secret, to know that that's a safe place to share that. It's a hard thing to do. But I think it is the most clear path to providing the best care for patients. And so, you know, if someone reveals to me that they're working as a sex worker to make money, that's the only way they've figured out right now to support their life, to pay for their housing, or to get their hormones, to get their health care, then I need to hear that information and not shut it down, not be judgmental about it, not condemn it, but to also then open it up to, okay, how is that going for you? Tell me about it. What resources do you have in your life? How can I help you get some different kinds of resources so that we can help you treat your body better? It's a powerful conversation to have with people, to say, thank you for sharing that piece of information with me. Thank you for being so vulnerable to share that. And I really appreciate your willingness to give me that information so I can help you better. Of course, willing to make mistakes and learn from them. I apologize frequently. I also say, you know, hey, you know, while you're here at our office, if there's anything that happens that makes you uncomfortable, that makes it hard for you to come here, please let me know. I know it's hard for you to say that to a doctor, but I really want you to tell me that. I try and give people permission. The power dynamic is so huge. People are, you know, if they found somebody who seems to be affirming, it can be really scary to risk that relationship, but I really want that feedback from them. And then of course, we're reflecting on our own implicit biases. So some other actions that are very, I'm sure many of you in this group who are watching this have done many of these things, but there's things you can do that are just very tangible, very, you know, in the space that you're in, that you can create it to be more affirming and welcoming. And one of the first things is to show up. People do not know we are allies. I have another colleague who likes to call it accomplices. They don't know we're allies and accomplices unless we tell them, unless we do something to say so. Most people are going to walk around assuming that we're not going to be open, we're not going to be okay hearing what they have to tell us. So go to your local Pride events, take part in events that go on in your communities, put on events in your communities, you can organize it. I think it's really important to put your name on websites. Like the GLMA, which used to stand for Gay and Lesbian Medical Association, or other various LGBTQ websites, so that people know to find you. Word will get out by mouth, but it's better to actually put that effort out there. And then of course you have to keep learning. There's so much to learn. I'm constantly going to trainings, reading things, watching movies or documentaries to try and learn more, to understand my biases. The language you put on your forms, if you're not already using inclusive language, you need to be using their preferred pronouns. And then just doing things like making your physical spaces more open, and welcoming to everybody. All gender bathrooms, putting up a rainbow sticker can mean worlds of difference for people of the LGBTQ population. This is an example of the kinds of intake questions we should have that separate out sexual orientation and gender identity, and doing the two-step gender identity question. How do you identify now? What's your current gender identity? And what sex were you assigned at birth? This way we can get more accurate numbers on how many people are trans identifying. There was a poster at NAPCRG earlier this year that was some research sponsored by the Rural Prep Micro Research, and they looked at what were the barriers for gender minorities. And one of them was confidentiality or privacy concerns. I recently saw a patient who is not out to their parents, didn't want to put their home address on their medical record in case something was sent there. So we were able to put our clinic address in place. So asking about confidentiality or privacy concerns. And rural transgender patients are more affected by physician turnover as well. So that creates a further layer of fears. So be a physician leader, role model, and demand a respectful workplace. Don't gossip or joke about LGBTQ people. Avoid asking unnecessary questions out of just curiosity. Use the person's preferred name and pronoun. And keep in mind those biases that exist on all those levels, those individual, what is the person's grappling with, and what ways do they not believe in themselves or have a lot of self-hatred that leads to those deleterious coping mechanisms, your interpersonal, how you're interacting with them in the office, and then those social and structural barriers that are part of our system. What can you do as a physician leader to break those down?